Recording in progress.
Good afternoon, everyone. Good afternoon. My name is Tanya Dixon. I am the Director of Programs and Strategy here at EHI. And I'd like to thank everyone for joining the session and for being with us this morning for Digital Health Equity Summit. This is a really exciting time for us over these next 2 days, this being the first summit. And also, we have so many speakers that are lined up, and there's a lot of really interesting conversations that we're going to have. And I hope that you enjoy them. With me this afternoon is Matt Turner. He is the VP of Product Management from Change Healthcare. And he and I were just going to have a little chat, just one-to-one, just for us to talk about his own insights with SDOH and to really talk about how data is changing healthcare delivery and what he sees coming in the future. Matt, welcome. How are you today?
Doing great. Thanks for having me.
Okay, on mute. Okay, so Matt, I want to start by just asking a general question. Thank you. Oh, you did?
Yeah.
Hi, Matt. Can you hear me?
I can. Thanks for having me.
Matt, can you hear me?
I can hear you great now. Yeah, we didn't hear your question.
Okay. I apologize. I'm sorry. I was having a great conversation with myself. You know, this is technology live and in motion. You just have to like roll with it. And it's Wednesday. So I'll repeat the question. So the question was, who are you? Just tell us about who you are and what brought you to us today for the Health Equity Summit. Who is Matt Turner?
Oh, thanks for having me. I'm the Vice President of Product Management for our Data Solutions Group at Change Healthcare. We're one of the largest commercial clearinghouses in the country and a digital health platform company, and just honored to be part of this summit and to be connecting with individuals here. This topic is near and dear to me. As you're sharing, I grew up in a small town in southeastern Kentucky. My town had one high school. It had no interstates. It had no railroads. But it's a beautiful area. In the foothills of Kentucky, things are beautiful, but economic instability, poverty, various other factors have led to disproportionately poor health outcomes. Many people lack insurance, social support. They just don't have access to good health care. And, you know, drug abuse, the opioid epidemic have hit this region really hard. And, you know, shrinking tax bases have not allowed these communities to invest in the ways that they would like to into social programs. So, you know, all of these factors really inspired me to get into healthcare. You know, the social determinants of health for these individuals, their education level, literacy, access to high quality food, economic instability, and a lot of chronic stress makes it really hard to find wellness. And so after high school, I packed up, I went to college, ended up getting a graduate degree in public health at University of Kentucky, and began working in hospitals, working with healthcare data firsthand. And so after a number of years of doing this, came to Change Healthcare because I wanted to work on this problem at scale and really to look across the US healthcare ecosystem and see how we can close the gaps on some of these social determinants and improve health equity across the country.
You know, that's really inspirational. I think that your story and your background is very common to so many of us, just no matter where we are across the country and even across the world. And I find it to be very interesting the path that people take into healthcare and the different modalities that they look at in healthcare. And for you, you focused on social determinants, and you talked a little bit about the health outcomes and where you grew up. And of course, we know that there's a direct link between social determinants and health. So tell me this, in what ways are health outcomes driven by social determinants? And, you know, what are some of the examples that you can present to our audience today?
Absolutely. No, thanks for letting me bring along a couple of examples here. So, you know, if you look at a macro trend of the country, We can see differences in economic stability. I don't think this is news to anybody. If you look at census tracts or zip code level data, so this is an economic stability index that we have, and you can start to see some patterns here. But individual zip codes, census tracts, regions, these averages pull together measures of economic stability that include market behavior, financial activity, financial attitudes. It puts patients into clusters, individuals into clusters. And those population insights are really great if you're building a public health program, if you're doing network planning. But I would make the argument that they don't reflect the individual live life experience of everybody in these communities. In short, people are not averages. And these individuals in the most economically challenged regions, we simply need better data as an industry to understand these. So let's, if you don't mind, let's go a step deeper here, and
Okay.
we'll talk a little bit about my home state of Kentucky that I love so much growing up here. And you can tell not all the counties and zip codes are the same. You can clearly see Appalachia on the right hand side here, but you do see a few pockets here. And so let's kind of see how multidimensional patient journeys can tell a better story here. As we discussed, this is a state that's no stranger to economic instability, and these macro trends will go down even one level and look at a particular community right in the middle of the state. So this is Fayette County, Kentucky, which is Lexington, Kentucky is the city there, and it's the grouping of the most stable economic zip codes in the state. It's home to University of Kentucky. It's much more affluent than other parts of the state. Certainly has higher capita of education, and just the social determinants macro look very different than the rest of Kentucky. But as you go a little bit deeper and look at the actual experiences of individuals in these communities, you still find things in that least stable cluster that we thought were insightful. So our data shows that individuals in the lowest cluster of economic stability have higher prevalence of chronic conditions such as COPD, hypertension, type 2 diabetes. This tracks across age. In fact, we were sort of shocked to find out that this population is on average and median younger, in fact, and still has those higher prevalence of chronic conditions. And this less stable economic group is more likely to use more acute settings of care. They're more likely to go to the ED. They're less likely to have primary care. And to see this in the data very objectively just reinforces the fact that these patterns lead to not good outcomes and certainly higher cost of care. And I think this is alarming. So even in a state where you take the most economically stable area, you go deeper into the data, we've got to have a more comprehensive, actionable set of data to do this type of work.
Absolutely. Data definitely is key to understanding and identifying where the greatest needs are and where the gaps in healthcare delivery are. And I think that became even more apparent during COVID-19 at the start of the pandemic, when we started to pay closer attention to data and really understanding like the whole story around healthcare. And we talk a lot about data. We've been talking a lot about data for the past 18, 20 months, and we'll continue to talk about it. But it leads me to think about, in what ways as an industry have we succeeded or failing to accurately capture data, and making sure that we tell that story in a way that people aren't just defined by their zip code or defined by what the data says. So do you have any thoughts about that? How has industry succeeded or failed in how we capture our data?
It's a hard problem. It's a really hard human problem. And, I think if we all hear this number that, 80%, 20%, I think has become sort of accepted that, 20% of the patient's journey happens within the walls of the medical center. And I would make the argument that we know that data incredibly well, despite challenges around interoperability, and we still have a ways to go. Since we've implemented electronic medical records, since meaningful use, since these programs that we've built upon this, we know that very, very well from a data perspective. But the other 80%, we don't in many cases. And even when we think we do, I would argue that not all SDOH data is created equal. As I said before, people are not averages. Just within that one Kentucky example, there's different outcomes. And so as the industry's tried to look at a standard approach towards SDOH data population, they've typically relied on census level attributes. So census blocks, census tracts, or maybe even like a zip 4 type of approach. And as you start to look at those householding or neighborhood attributes, or even higher levels, such as county or state, these things just sort of fall apart. One of the analogies we use in our team all the time is, I can have 1 foot in boiling water and the other in a bucket of ice. And on average, I'm doing great today, but that's not telling you my live life experience. And, we got to get better at this. And so to do that, we at Change Healthcare have taken techniques from other industries. We focus very heavily on identity resolution, our
Mhm.
always on compliance offering and governance around this data. With great power comes great responsibility. You have to take privacy and these type of approaches very seriously. We've instantiated that in software. We've built that in. But what that results in is a very curated, multidimensional patient journey that's data driven.
Yes. And I think that's really important, really affecting and improving the patient journey. Because there's so many determinants of health outside of the social determinants. We know there's the structural and there's policies and systems. And so what are your recommendations for integrating social determinants into the patient journey? And what does that look like if we were to improve that?
Yeah, I think it's always a difficult challenge. I mean, each part of the U.S. healthcare system is so complex. We're working hard on this, and we don't pretend to have the answers. I mean, I guess, as I said before, this is a difficult human problem, but I believe that every stakeholder, so whether you're a provider, a payer, a CBO, like whatever you're doing, you're part of this difficult equation. You must have high quality data on health related behaviors, attitudes, preferences. You must understand the live life experience of the individuals that you serve. If you want to improve outcomes, increase engagement, manage risk, whatever you're trying to do, data around the social determinants of health is no longer optional. We've got to have it. It's got to be in our decision making. It's got to be at our fingertips. And so, again, that's why we've tried to create a multidimensional patient journey to lead the way, to push the dialogue forward on having much more than clinical encounters to make decisions, far more precise than census tract level attributes, data at scale. Where programs like perhaps patient-reported outcomes and Z codes have been, really altruistic in their goal to push the industry forward, but they just haven't yielded results at scale. And so we're trying to create real actionable information that we can use for better decision making. And I think to do that, you need individual level of specificity.
And so you mentioned just briefly patient-reported outcomes. Why do you think that hasn't yielded the results that we expected it to? Because one would just assume that if I express my social need, then there should be a solution that's offered to me, or I should be able to talk to my provider. So why do you think that patient-reported outcomes haven't worked as well as we expected them to?
Yeah, if you need help, raise your hand. Right? And look, I hope that you are going to have many speakers here at your summit who are going to tell their wins and their successes with patient-reported outcomes.
Yeah.
No doubt they've made a difference locally in individual communities where these needs have been identified, gaps have been closed. It's just phenomenal, the stories that we're hearing. But at scale, these are tough, and I think there's a lot of things going on here. Early on, I don't think the electronic medical records made a place for that. It wasn't in the workflow. I think that's getting better. But our providers are on serious time crunches to see patients. Never before have they seen these types of pressures. And so extra documentation is not always the easiest thing. And in that case, there's a lot of evidence that says that patients are not always open with this information. They maybe don't want to share this always. And there's certainly evidence that points to they will do that in certain circumstances, but there are different cultural attitudes, behaviors, and some patients don't make it to their providers. And so, if they're not making it to those appointments, it's very difficult to gather that information.
That's a really good point you brought up about the trust factor. I think that's something that we're going to talk about at the summit later, and talking about some of the cultural needs that patients have and that providers can fulfill. With that, I can't believe 15 minutes has passed us by so quickly. We could definitely talk on, and you and I, we have had a lot of long, lengthy conversations about SDOH and health equity, and we'll continue to have more. So I just want to give you the last moment. Do you have any closing thoughts? What do you want people to walk away from and walk away with today?
Yeah, I think as this backdrop kind of says, there's significant effects from externalities, is that these behaviors, these attitudes, they're a big deal. And I know that I'm preaching to the choir a little bit here today with this audience, and I'm just so excited to see the
Mhm.
enthusiasm from your summit, your organization, who are really getting after this. We've talked about this in the industry for some time. It's really refreshing to see us do something about it. And I think weaving this into every piece of our healthcare system to close these gaps is the hard work before us. So I look forward to many more of those chats about this, and I appreciate you for having me today.
Yes, thank you. Thank you so much. Thank you so much for joining me, Matt.